Hi everybody. My name is Arber Aliu from the Service of Cardiac Surgery Clinic at the University Hospital Center Mother Theresa in Tirana, Albania. Today I will present a challenging and interesting case entitled From Catheter to Heart, Giant Right Atrial Thrombus and Concomitant Cardiac Surgery as Gold Standard Treatment. This case highlights the diagnostic difficulties and the multidisciplinary management of a giant catheter-related right atrial thrombus in a hemodialysis patient with concomitant severe coronary artery disease. Intracardiac masses represent an important diagnostic and therapeutic challenge. When a mass is identified inside the heart, the differential diagnosis usually includes thrombus, vegetation, or cardiac tumors. The first diagnosis when the patient appeared in the hospital was suspected as vegetation on the tricuspidal valve, but after some diagnostic procedure, we concluded that it was a mass intracardiac, and then we'll behave as according below. I will show you. The pathophysiology of the catheter-related thrombus formation can be explained by Virchow triad: endothelial injury, abnormal blood flow, or hypercoagulability. As we know, the famous Virchow triad. Hemodialysis patients are especially predisposed because long-term central venous catheter can damage the endothelium and create turbulent blood flow within the right atrium. Additionally, chronic inflammation and comorbidities increase the thrombotic risk. These patients often present with non-specific symptoms, as our patient, making the diagnosis difficult. However, the complication can be catastrophic, including pulmonary embolism, sepsis, infective endocarditis, right heart failure, and sudden death. Therefore, early recognition is extremely important. Here we can show you the thrombus inside the vein or inside the superior cava vein or inside the right atrium. It can be in the top, in the tip, inside, or it can be a giant thrombus in the end of the catheter, which may be mobile or adherated with the atrium wall. The size and mobility of the lesion are directly associated with embolic risk. Management options include conservative treatment, the first options, with anticoagulation and antibiotics, or surgical intervention. The choice depends on lesion size, mobility, persistence despite therapy, suspicion of infection, and associated cardiac pathology. According to our patient, he was a male, 49 years old, who presented with chronic kidney disease on hemodialysis. He presented with fever and the right atrial mass detected during imaging evaluation. Initially, the patients received antibiotics and anticoagulation therapy for approximately 1 month. Despite treatment, the mass persisted. So both transthoracic echocardiography and transesophageal echocardiography identified a large, pedunculated, and highly mobile right atrial mass. So we decided to intervene. Here are the images from the echo. This is the large giant thrombus mass in the right atrium, which it gives the image that it's a mobile mass. But what we will see in open heart, it was adherated in the atrium wall. So the mass measured approximately 5 centimeters square and appeared attached near the catheter entry point in the right atrium. This strongly suggested a catheter-related thrombus. Given the size and mobility, the risk of pulmonary embolism was considered very high. Further diagnostic workup included thoracic CT scan, which confirmed the intracardiac mass, neurological evaluation because the patient had symptomatic epilepsy, and laboratory investigation showing elevated erythroid sediment and bilirubin while the complete blood count remained normal. These findings supported an inflammatory process but were not definitive for infection. This is another point of view you can see from the echo. Here is the angiography. As we can see, it's a three-vessel disease. But we decide to skip the marginal because it was a small coronary artery in diameter. So we decided to go through surgery. The reasons because of large mass, persistent despite therapy, suspected infection, and concomitant coronary artery disease. The operative plan included complete of the right atrial mass, removal of the dialysis catheter, and coronary artery bypass grafting with 2 grafts. These under general anesthesia, median sternotomy, pericardium opened, aorta and vena cava cannulated. What we do in cannulation with superior vena cava, we cannulate it in the distal part of the vena cava because from the CT scan it was diagnostic that there are some thrombus mass in the origin of the vena cava too. The catheter is slightly pulled out externally from our anesthesiology, so it was, but not removed yet. It was just slightly pulled out, but not to remove the full catheter because of the risk of this mass. Thrombus mass can move from the right side of the heart to the pulmonary to cause the fatal risk of pulmonary embolism. Intraoperatively, the mass was attached to the atrial wall near the inferior vena cava. Macroscopically, it appeared to be an infected thrombus. The lesion was completely excised, and the dialysis catheter was then fully removed. So I can say it again. After the aortic clamp and under the extrapulmonary circulation, then we pulled out the full catheter. The samples were sent for microbiological and histopathological analysis. Here is the right atrium opened, and we saw attached to atrial wall near it was in fact near the inferior vena cava, the large mass of 5 centimeters square. And here is after it was exceeded. After that, we were more sure to pull out all the catheter, fully catheter, because it may be infected, blocked, or just to be sure. Coronary bypass grafting was subsequently performed, PLENO-IDEA, and saphenous vein graft to posterior lateral branch. Reperfusion was successful. The patient was separated from extracorporeal circulation without prolonged inotopic support. Postoperatively, the patient remained hemodynamically stable. No minor complication occurred, and ICU recovery was uneventful. In follow-up, a postoperative CT scan of the head showed no acute findings and was compatible with the patient no epilepsy, because in the first night we had a seizure and we thought if it was a stroke or not. So for sure the next day we did a head CT scan. We in follow-up, echography showed no residual mass. Histopathology showed fibrothrombotic lesion, but no malignancy. So it was not a tumor. The patient underwent gradual mobilization and was discharged after 10 days. He was discharged on anticoagulation therapy and antibiotic. The postoperative evolution was very good. About the discussion, catheter-related atrial thrombi are rare, but incidence is 5%. It's not correct this here, and mortality is 15%. Risk of pulmonary embolism and infection. And transesophageal echography is mandatory. Our studies suggest that the best position of the central catheter, permanent central catheter for hemodialysis, is inside the superior vena cava, not inside the right atrium, because as the study showed, the catheter inside the right atrium was predisposed to form a thrombus mass. So, in high-risk patients, surgery is often a preferred strategy. Concomitant surgery, gold standard when coronary artery disease coexists. There are many books or studies that support these outcomes, and our patients too proved that the surgery was gold standard. In conclusion, early diagnosis is crucial, because to avoid the fatal complications like pulmonary embolism and heart failure. Surgical treatment represents the gold standard, as we said, because of the concomitant pathology. In this case, no discussion. But very important is a multidisciplinary collaboration, ensure the best outcomes. This case demonstrates how timely surgical intervention can successfully treat both thrombotic and ischemic cardiac disease simultaneously. The main learning point from this case, first, there are currently no universally established guidelines for management of complex catheter-relating right atrial thrombi. Second, early surgical evacuation should be strongly considered in young patients with giant thrombi, mobile lesions, concomitant coronary disease, or suspected infection. Finally, frequent echocardiographic surveillance should be recommended for patients with long-standing dialysis catheter positioned in the right atrium. Because if we want to prevent the fatal risk, it's better if we recommend the patient to do frequently echocardiographic echo. Thank you very much. Open for any question.